Production and distribution of City Club forums on IdeaStream Public Media are made possible by PNC and the United Black Fund of Greater Cleveland, Incorporated.
Hello and welcome to the City Club of Cleveland, where we are devoted to conversations of consequence that help democracy thrive. It's Friday, July 15th, and I'm Dr. Akram Boutros, President and CEO of the Metro Health System. I am pleased to introduce the first of 4 conversations at the City Club about creating a continuum of care for mental health and substance abuse in our community. This behavioral health series is presented by the Metro Health System with additional support from the Sisters of Charity Foundation and the Woodruff Foundation. I reached out to the City Club to host these gatherings because the behavioral health crisis that is threatening the welfare and safety of all of us, and it deserves attention from each of us. This was true before COVID, and it is still true today. In fact, after 2.5 years of disruption, isolation, and uncertainty, the behavioral health epidemic, which previously had gone unnoticed, is even worse. I am fairly certain that we are looking at a decade of behavioral health and addiction fallout that will far exceed the medical toll from the COVID-19 pandemic. I realize many of you are quietly aware of the impact of mental health and addiction is having on our friends and families. The escalating crisis we will face is beginning to manifest in an endless wave of mass shootings, most of them perpetrated by young men who appear to be struggling with untreated mental illness. Less prominent are the routine and daily deaths from homicides and suicides that plague our major cities. According to the CDC, nearly 60% of gun deaths in the United States each year are suicides. When looking at the number of suicides, white men are 6 times as likely to die by suicide than other Americans. In 2020 alone, the firearm homicide rate increased nearly 35%, reaching its highest level since 1994. Black men are 17 times as likely to be killed with a gun fired by someone else. Among 14 to 25-year-olds, overdose deaths are 4 times what they were 20 years ago. Homelessness and incarcerations due to mental health issues are rising at an alarming rate. This story is not other people's story. It is our story. If you and your family have been spared so far, you will not be for long. If it seems like I'm trying to alarm you, I am. I want to alarm us into caring, into action, into solutions. These diseases, and that's what they are, diseases, not character flaws, are striking people in every corner of our community, on every rung of the economic ladder, in every age group. Unless the audience thinks I'm criticizing our mental health and addiction professionals, I am not. We are blessed to have people and organizations throughout this community trying every day to weave a behavioral health safety net that catches those in need. You're going to meet some of them today. But despite their good intentions and best efforts, the needs are so great and our safety net so filled with holes that too many of those we love fall through. I am critical of the outcome, not the people. We must do better. With new leaders emerging in government, healthcare, a nonprofit organization, Now is the time to boldly act in mitigating this crisis. Our community and our humanity are at stake. Here with us today to discuss important issues pertaining to behavioral health care is Dr. Michael Bascaro, Vice President of Behavioral Health Services at St. Vincent's Charity Health Campus at the Sisters of Charity Health System. Dr. Julia Bruner, Senior Vice President for Behavioral Health and Correctional Medicine at the Metro Health System. Eric Morse, President and CEO at the Centers, and Jessica Vasquez, Mental Health Specialist at the Right Direction Behavioral Health Services. Moderating the conversation today is Marlene Harris-Taylor, reporter and producer at IdeaStream Public Media. If you have questions for our panelists, you can text them to 330-541-5794. That's 330-541-5794. You can also tweet them at the City Club. The City Club staff will try to work them into the second half of the program. Members and friends of the City Club of Cleveland, please join me in welcoming our panelists and Marlene Harris-Taylor. Marlene?
Thank you so much, Dr. Boutros, for that wonderful opening statement. You really laid the ground for this very important conversation that we're going to have today. And I'm so honored to be back on the City Club stage. This is my first time back in person since what some people call the before times. So I'm so happy to be here today. And we're going to start off by what might seem like a simple question for the folks in this room, but for many people who might be listening, they may be wondering, what exactly is behavioral health care? It's a big term, so let's start by defining it. Michael, I'm going to start with you and ask you, can you share with folks, what is behavioral health care? What does that mean?
Well, before I answer that, I want to thank you and Dr. Boutros for that introduction. Thank you to the City Club for inviting us here. Thanks to the panel, but really thanks to all of you who work tirelessly with us to address these issues that are facing the most vulnerable in our communities. But behavioral health, first of all, it's healthcare, right? Behavioral health is healthcare. But it's really an umbrella term that defines how we describe any mental, emotional, or addictive disorder for individuals. But really, I want to bring it back to it is healthcare, and it's important and critical for us to address.
And Julia, I'm going to ask you to come in on this conversation because you mentioned that, there is some, it's not really settled within the community exactly what it goes in that bucket. Different people put different things in the behavioral health care bucket.
Yeah, so for many people in healthcare, understanding how we term mental health provider versus behavioral health provider, it can be a little confusing even to nursing staff, primary care physicians, specialty physicians. It is a new term within healthcare, and the intent of it is exactly what Mike shared, which is we really want to ensure that it's encompassing all the needs in relation to mental, emotional, and care for addictive illnesses. But it's something that part of the challenge with this has to do with the licensure related to the professionals in the field. And that creates a lot of misunderstandings as to who can do what in the field itself.
Ah, I see. Now, let's move to talking about the larger issue, one of the big issues we want to talk about today, which is the behavioral health, now that we know what that is, the continuum of care in our community. Do we have a full continuum of behavioral health care in Northeast Ohio? And I'm going to start with Jessica to talk about that.
I would say that when you're thinking of continuum of care, you're really wanting to encompass how are we collaborating at different levels. So I do feel that in Northeast Ohio, there is such a strong push for how our hospital systems that now have behavioral health centers our education systems, collaborating with our mental health agencies. So I think we're looking at it as a big puzzle, and what are all the pieces that we can be putting into that puzzle to really provide that continuum of care that's so necessary, but also has a lot of elements to it. So we're here speaking on behavioral health, but within behavioral health is their physical well-being, their mental well-being. So it's quite a large scope. And I think that Northeast Ohio is headed in that direction, and these conversations are very crucial to what do those next steps look like to really bring it all together.
You're right, it is a large scope. So, Eric, how are we doing on it? What's your assessment?
Yeah, so when you think about the continuum of care, which really starts with prevention through outpatient services to crisis services, and then inpatient, and then hopefully back into the cycle of starting with outpatient, all the ingredients are here in Cuyahoga County. I think there are two issues getting in our way. One is, actually it's three issues. One is workforce, that there aren't enough people going into this field for a number of reasons. One of those reasons, which is the second issue, I think, is that the reimbursement system is inadequate and not set up to properly incent the right activities. And then third is that it's very bifurcated. There are each organization kind of does their own thing, and the continuum doesn't necessarily make it easy for someone to get through the whole system, depending on what your circumstances are. If you have Medicaid, your experience is going to be one way. If you have commercial insurance, it's going to be a different way. If you're uninsured, it's going to be a different way. It's really hard to navigate. I mean, I can speak personally. So I've been in this field for over 20 years, and when my kid needed something, it took me 4 months to get her into an appointment, right? And I know the system. I know how to get her in. That's how difficult it is right now to achieve care.
So imagine if you're someone who doesn't have your knowledge.
Right.
And we talked about that there's a communication issue. Like, communication is key for everything, right? And communication is key in making sure we fill the gaps, right, Julia?
Yeah, so at this stage, in relation to how our communities and our nation are interested in improving mental health, and the stigma is being addressed on a daily basis. I don't think a day goes by where I don't hear a comment on the radio or a comment on TV around mental health awareness and people wanting to ensure that everyone knows that it's okay to reach out.
Yes.
The challenges that we face in the current network as it sits is there's little connectivity between the organizations in Northeast Ohio. And building that connectivity is our opportunity as a community to really ensure that handoff in relation to a child who needs support in a variety of different ways goes to the right provider, and if that need changes, that person that's providing that care knows where to go next and does it in a way that's simple and easy for them to do, that doesn't take 3 days to figure out.
You know, you mentioned children, and there was a really, devastating story recently. There were media reports of 2 Cuyahoga County Division of Children and Family Services workers making allegations about the Jane Edna Hunter Social Services Center. They alleged rampant violence, abuse, and sexual assault, unsafe conditions, staff being assaulted on the job, human trafficking, and even rape. I mean, it was just shocking, I think, to the community, and very sad, and everybody's heart goes out to, everyone involved, especially the children. So when people hear things like that, they're like, wow, we're dropping the ball somewhere in our community. Where are we dropping the ball on that? What do you think, Eric?
I wish that was a simple answer.
Yeah.
Just dropping one. It's like we're dropping 30 balls.
Okay.
To get us to those circumstances. And those stories obviously are heart-wrenching, heartbreaking. But they're a symptom of a much larger problem, a very large, complex problem. We've been in, the centers has been in conversations with the county, trying to work on what is the right solution, along with many other providers like Guidestone, who's in here. There are a lot of people trying to solve this problem, but these are kids the whole system has failed. When they end up there and there's literally nowhere else for them to go, to the point where children's services workers have to care for them, which is not what their role is. And God bless them for the work that they've been doing their best to keep those kids safe. But it really is our system has failed them, and how do we bring a different solution to help those kids stabilize and then become, important members of the community, instead of kind of what's set up now, where a lot of those kids are going to end up in systems that, like the criminal justice system or worse.
Right. I know, Julia, I think Metro Health, I'm sure, is trying also to help in this situation, because you guys are a big player in this community.
So we have a close link in relation to their medical care with the foster system, and we have worked diligently with many team members from our population health, from the Institute of Hope, from our peds psychiatry, peds psychology, from our medical teams, to really support the needs from a health perspective for these children. And we will continue to help focus those needs and help with that as much as we can.
So Michael, what did you think when you heard these reports?
I think it just shows the incredible need, shouty caps need, right? I mean, there is an incredible need out there. Eric, right, it highlights the difficulties with the system. And I think this really is not only that, what we're hearing there, which is tragic, but just the way things have been for the last 2 years, right? Everybody's struggling. Everybody's having a difficult time. And this is really our time to all come together and figure this thing out and do it right and do it well, again, for the people who really truly need it most.
You're right. Everybody's been suffering, especially children, and people are really worried about, especially on the mental health side for children. And Jessica, I know you work in the school system, so tell us what you're seeing, how are our kids doing, and what do we need to do in the schools to make sure that there are no gaps and we don't have people falling through the system?
Yeah, right now, coming out of what the children went through, including the pandemic, a lot of our children have experienced a lot of trauma. What we're seeing in the school buildings and the classrooms is very worrisome in terms of the high need that there is for addressing behavioral health, as well as where is everybody who can help, and how are we coming together, how are we collaborating. I know a lot of our schools in Northeast Ohio have built partnerships with behavioral health agencies, and that's an amazing start. But when we talk once again about that continuum of care, it's what does that collaboration look like? What are still the links that need to be addressed, so that when we're looking at our educators and those in the building, how are they best prepared to recognize our children in need? And for our educators, many will probably be able to connect with the fact that in a lot of instances, we're looking at tier 1. So we're looking at universally, our children are coming in, and the majority of the population in a school could have experienced trauma on a lot of different levels.
So considering that, is there enough help in the schools? Because obviously, it sounds like the need is huge. So is there enough help there right now?
I would say that many would agree there's not enough help. Our schools are now looked at as where we can provide health care, mental health care, in education, social emotional learning. So given the responsibility now put on our educators and those working with children, there's not enough.
And teachers are having to do a lot of this themselves, right?
Yeah, a lot of times they're that first point and the strongest point of contact with the children they see day in and day out. So when they have the responsibility of educating them in their academics, connecting with them emotionally, building that relationship, and trying to figure out who are those that can come in and really help, because one person can't do it all. One school building can't do it all.
Michael, did you want to jump in there?
Well, I was just going to, say is why? Why, if we have such a great need, do we not have it? Do we not have what we need to provide that care? Do you think we have this problem in healthcare in general? I think that I think until behavioral health is no longer kind of the underling of the healthcare system, are we not going to really make significant progress? I don't know that we'll solve all of those answers here today.
But that's an interesting point, though. So why is behavioral health an underling of the healthcare system? Why is that?
There's a lack of enforcement of parity to begin with. I mean, the federal government did pass a law that behavioral health care had to be treated as equal to physical health care, and it still isn't. It just isn't. I mean, there are 50% of the people who need help can't get help or don't get help. Of that, 30% of them don't get it because they can't afford it. And in Ohio, most people are insured. So not being able to afford it is because the reimbursement rates aren't correct, so they have to private pay, or there's a very small network. I mean, if this were about like heart attacks, no one would be like, oh, the network isn't adequate, you got to go out of network. Like that's absurd. So it really is a lack of enforcement. And I don't want to make it simple, like it's just the government or it's just insurance companies, because it's employers. It's all of us deciding, right? If we're going to pay more for behavioral health care, it's going to cost us more, right? Our insurance rates are going to have to go up. We have to commit that as well, right? It's not just on insurance companies and the government to make that happen.
So you're saying as a society, we're saying that this is important, but we're not putting our money where our mouth is? Is that what you're saying?
That's right.
And the educational requirements for counselors, for medical providers or health providers that work in this space, they're master's degree level trained individuals, and their ability to receive compensation for that level of education it's not equitable.
And why is that?
It goes back to our prioritization around what types of health care have the most importance in relation to our perception of health.
So how do salaries get determined and set or raised? How does that happen?
It has a lot to do with how the care is paid for and how it's reimbursed. And so it goes back to, it's a very complex space. It has a lot to do with how it's ranked in relation to Medicare and how they reimburse.
By the government?
By the government, yes.
Okay.
Yes.
So private institutions, private hospitals, or even nonprofit hospitals have no say in setting these rates outside of reimbursement from the government or private health insurance companies?
So there are ways that we can change this, and there are ways to change it in relation to how we look at the value of mental health care and how we reimburse it. If we started looking at mental health care in relation to improving behavioral health and its outcomes in relation to health overall, and we look at pay for performance in relation to that care, that's, I think, where we will gain more interest from a society standpoint and from a payer standpoint, if we are able to show that when mental health care is provided in a phenomenal way, medical problems are not as severe, or they're more controlled in that space. And there are studies that are continuing to show that. There was a study done that was published by the VA this spring that showed that veterans who had a platform in relation to telehealth for their psychotherapy had lower incidences in relation to going to the emergency department, not only for suicide events, but also for medical conditions.
So this all kind of starts with how workers are reimbursed from the government, and that sort of starts the whole system and continues to perpetuate the lower salaries. So
that's a piece of it, right? If we recognize the value of a counseling session at a level for a 60-minute visit with a professional, at a level that's the same as a 15-minute visit with a primary care doc, that shows you the potential gaps in relation to that reimbursement, because that mental health provider can only do so. They need 60 minutes with that patient.
Right.
They can't do it in 15.
Right. So is this then also tying into the worker shortage that we're seeing? I know that as a society overall, we're having a worker shortage, right? Everybody, there's help wanted signs everywhere, right? But this is particularly stark in healthcare and behavioral healthcare, is it not?
It is. So in our industry as a whole, there are many people who are aging out, who are retiring. They're at that age where they can retire, and they are ready to do so. And there is a lack of abundance of people in the workforce who are taking their place. That being said, I think in the current younger generation, in the teens and the 20s, I don't know what that generation's called. I'm not sure.
I don't know. Are they Zs?
I don't know.
Does anybody know? I think it's Gen Z.
Gen Z. That generation is actually very interested and motivated, not only in work that is mission driven, but also interested in mental health.
Yes.
And I think we need to tap into that.
Yeah.
We need to tap into that and support them, getting them through school, so that we are able to build that workforce.
But do they know the salaries?
Well, that's why we need to support them to get through school.
So that could be established to be more incentivizing, along with, I think it's very important that, we also address, when you disaggregate the data of who is going into this profession, or just in higher education in general, there's a reason why when I graduated and was going through school in 2015 to 2016, I was still there because of an underrepresented scholarship. So when we're looking at our those in training, those of color, that would be well represented in terms of who they're treating.
Yes.
We're seeing a big gap there in terms of, for example, we may have a high need of, let's say, children, adolescents, even adults from different ethnic, racial backgrounds, but those servicing them do not appropriately represent them. So even looking at our training programs and who's being supported in getting through school and what these training programs are looking like. How can we be structuring this in a way where we are well prepared, but we don't have to go through so many years of training and so many obstacles to get a license? And what does that look like when you train one place and you go to Ohio, or you then move to Florida? So systemically, there's many things that I think can be addressed to help us bridge that gap of that high need, but needing our workforce to mirror that.
Yeah, cultural competence is so important because often people would like a provider that looks like them, right? So what are you doing at the centers to address the shortage of workers?
Well, a few things. We've over the last year really worked to figure out how we could push wages up. It's definitely a bet on ourselves because the reimbursement rates don't necessarily support those increased salaries. But if we don't do it, we don't have people, right? And we're not going to be able to get the work done. So we're taking that move. The other thing is that we're shifting. We can't just wait to fill all of our workforce positions. How could we also look at how we provide services so that we can reach more people with the resources we have? And so this next week, we're opening 2 behavioral health urgent care centers, which will be the first in Cleveland, I think, one of the first in Ohio, where just like if you break your ankle or whatever, or you sprain your ankle, you go to urgent care, right? That if you're having some sort of change in your behavioral health symptoms, or maybe you've been suffering with depression and you're finally ready to go get help. And we know that if you're in that boat and you call to get help, it's going to be a while before you get in, right? And so with this system, if you're finally ready to come in, then just come in, right? Call or just walk in the door, and we have a team of people, a social worker, a psychiatrist, or nurse practitioner, a care coordinator, nursing, who can wrap all those services around someone, get them started on treatment, and then do that ongoing linkage and kind of be that bridge in between that emergency or crisis and when someone can actually have ongoing care.
And so how is this manifesting at St. Vincent Charity in terms of the worker shortage? What obstacles are you having in terms of making sure everybody can get care that needs it?
Well, what I'd say about workforce is obviously, at the health system, all of our ministries are struggling just like everybody to get people in and provide care. I think certainly, the demand is outstripping supply, and we need to do a lot of things to correct that. We need to get younger folks interested in this field way earlier, right, Nick? You need to get younger folks interested in this field much earlier, and we need to support them as they do that. I myself had, a high school student with me at our system, and who's really interested is going to be a wonderful psychologist one day, maybe a social worker or a counselor as well. But you know, she, you know, we really need to invest in our younger folks, and we also, you know, we also really need to leverage those disciplines that give us lived experience, peers. We're seeing the rise of the community health worker. Wouldn't it be great if we could combine those two roles and have people with lived experience in mental health, addiction, and homelessness, but also with community health knowledge that's a trusted resource in a community? There's a lot of things we can do, we just need to start doing them.
Well, you know, one bright spot, and I assume it's a bright spot, is that tomorrow the 988 line goes into effect, and that's the line that we're hopeful that people will begin to use if they're having a crisis situation, particularly around suicide. So there was a 1-800 number that people have to call now, and then starting tomorrow, this will be available in our community. I'm assuming that this is, you know, welcome. Julia?
Absolutely, absolutely. I mean, to make it easier for people to have access to finding out what resources they have, ensuring that they have access to support if they need it, and how to get to the emergency department if they need to get to the emergency department, or how to connect with the center's urgent care. We need that. We need that, and that's going to be
Do we have any challenges locally about making sure, you were talking about staffing shortages here, do we have any challenges locally making sure that there's somebody there to answer the call?
I think this is where we just need to give kudos to the Adams Board of Cuyahoga County, because they have really been just instrumental in planning this out. There's places in Ohio that are not ready, right? And so it's a big lift to change your system over, and they've done a great job working with their partner at Frontline Service to make sure that's ready to go tomorrow, and that there's someone to answer the phone.
We're ready in Cuyahoga County. I'm sorry, I didn't mean to cut you off there.
No, I was just going to say, can you imagine right now if we were talking about, hey, tomorrow 911's coming online? I mean, seriously, like, I mean, and so thankfully, we finally have a number that's super simple that anybody can call when they need it. Certainly, we're going to see how that whirls out. City Club will be talking about crisis care in a few months, and we'll probably be able to talk about that then and hear about that then. But I mean, yeah, this is wonderful. What we probably still need, though, is some infrastructure to go along with it, right? So we'll see how this number really connects everybody, like we've been talking about, right? How does it connect everybody? How do we talk to one another? How do we coordinate the wealth of resources that are in this county? But it's certainly a miraculous step.
All right, so on that note, we're about to begin the audience Q&A. And again, I'm Marlene Harris-Taylor. I'm the managing producer at Health at WKSU IdeaStream Public Media. Today, we're talking about creating a true continuum of behavioral health care here in Northeast Ohio. Joining us is Dr. Michael Bascaro, Vice President of Behavioral Health Services at St. Vincent Charity Health Campus at the Sisters of Charity Health System. Dr. Julia Bruner, Senior Vice President for Behavioral Health and Correctional Medicine at Metro Health. Eric Morse, President and CEO at the Centers, and Jessica Vasquez, Mental Health Specialist at Right Direction Behavioral Health Services. We welcome questions from everyone, City Club members, guests, and those joining us via our live stream at cityclub.org or on the radio broadcast at 89.7 IdeaStream Public Media. If you'd like to tweet a question, please tweet it at the City Club. That's at the City Club. You can also text to 330-541-5794. I'll say that again, 330-541-5794. And our staff will try to work everything into the program, all the tweets, all the questions. And I see we got a person at the mic, and let's go to our first question.
Good afternoon, thank you. My question is, where does Cleveland, this region, stack up against other similar size, both in availability of resource and especially in financing?
That's a good question. How do we stack up? Who wants to take that one?
Well, so there's a couple ways to look at it, right? I think Cleveland, Cuyahoga County does a really great job of their providers leveraging the resources that are available and bringing those resources into Cleveland. And I think we do it as well in Cleveland as we do anywhere else, any other large major city. I think the Adams Board funding, which comes through Cairo County as well as the state of Ohio, is probably somewhere in the middle if you look at like other bigger communities in Ohio, and could definitely use their own levy and their own resources to be able to really provide all the adequate services needed in Cairo County. So I probably put us right in the middle right now.
Yeah. When you look at publications from the state of Ohio, the areas of need throughout the state are largely rural areas that have absolutely no access to behavioral health services. So Northeast Ohio, Cleveland itself, has more access to resources than many other areas of the state and many other areas of the nation.
Yeah, I'd probably just add to that. I mean, if we're going by some of the data, we're 47th, 48th in health outcomes here. That's not good enough. We need to do better. We still have overdoses, right? 13 a day. We just got another alert another overdose alert this week. We still have, on average, 5 people dying by their own hand a day in Ohio, and that's also, not okay. So there's a lot that we need to do. We need to invest in this. We also, though, need to invest in quality, good programs. Have had conversation with Scott. There is only so much money and so many programs and so much need. How do you decide what to invest in and where? So I think that's a big discussion and something that's going to happen at both the federal, state, and local levels.
You mentioned the recent overdose surge. People may have heard about that in the news this week. What do you think is behind that? The rapid increase in the past few weeks, and it's been a steady increase over the past couple of years.
Well, yeah, I mean, I think that Dr. Yeltsin relayed that the majority of the overdoses over the last couple of months have been associated with fentanyl. So that's across our community at large. The pandemic, as Dr. Boutros brought up, it unleashed more behavioral health issues and more levels of crisis. The addiction crisis, the opioid addiction crisis, is a real health crisis, and it has been perpetuating for decades and continuing to grow. And we have to tackle that as a medical condition and treat it as such, and provide the services that people need.
And we have to keep investing in treatment. Can't stop doing that, but we also have to move upstream. Right? We have to start thinking about prevention, start thinking about other ways to solve this problem other than treatment. And I think we could probably talk all day about that. But that's it.
Also, a bigger embrace of harm reduction strategies. I mean, Cleveland is pretty progressive in this, but still not enough, right? Getting the Narcan out there for emergency use.
That's the drug overdose.
Right.
The overdose reversal drug, I should say.
Right.
Yes.
Sorry. Fentanyl strips, so that you could actually test whatever you're using to see if there's fentanyl in it. As well as when you're talking about opioids, you're also talking about needles and syringes, and making sure people have clean syringes for their use, because they're going to use they're going to use no matter what, right? To make sure that they have clean needles, so that we're not spreading HIV and hepatitis C and all of those other things that will kill people. To make sure they can get to a point where they can get into treatment, right? Getting into treatment is the ultimate goal, but we need to be able to provide those interim services.
There's a great deal of research ongoing in relation to the genetic components as they pertain to any medical condition, but of specific interest is addiction. Investing more in that, ensuring that people understand that when you have family members that have diabetes, and your parents say you need to watch your carbs, it's the same issue if you have family members who have addictive conditions. Mm-hmm. You need to be aware of it, you need to communicate that, and you need to be open about it.
Well, let's move on to the next question. We've kept this gentleman waiting a while.
Thank you. My question is for Ms. Brunner. There was a fascinating article in the Sunday, July 10 print edition of the Times about the increase in prescription drugs being taken by people since the pandemic. So my question is on treatment, not access. And one of the things pointed out was a study was done a few years ago that indicated some 79% of prescription drugs for depression, anxiety are written by primary care physicians, not by psychiatrists. So my question is there still a tendency to try to medicate people as opposed to talk therapy? And to paraphrase Dr. Phil, how is that working for us?
So with any healthcare condition, you can't separate out the medicine from the communication and the acceptance of how you have to have lifestyle changes. It comes hand in hand. And so for primary care has been, I'm a family medicine doc. Primary care has been the mainstay in relation to all healthcare conditions, recognition of illness, and treatment at its very beginning. And one of the things that brings great value in relation to treatment for any healthcare condition when it's chronic is ensuring that you are helping people adapt their lifestyle to that condition. And that's one of the wonderful programs that we have at Metro Health. We have integrated behavioral health within all of our primary care sites. And that really has shown and continues to show across the nation improved outcomes relative to care.
Do we have another question?
Yes, thank you all for being here. My question is, with the resource challenges that we have, how much consolidation of service providers are we seeing now, and what do you foresee in the future?
That's a great question, because we just saw a hospital here in town announce this week, UH announced some consolidation of services, so it's happening and it's real.
Yeah, I mean, I think if you look into the future, I think most of us who are in this field see consolidation coming soon. There's also, you can't just do behavioral health. You need to add in that integrated primary care, whether it's through a partnership or at your through your own organization. You know, it's interesting, the behavioral, if you think about behavioral health, it's like, go back to like medicine in like the 1950s, right? There are so many private practitioners out there that even beyond just the organization, the number of organizations in Cleveland or in Ohio, beyond that are all these private practitioners who are out there. And that, when you have that, right, that helps keep prices low, right? That helps keep reimbursements low because there's no bargaining power, right? So yes, I think consolidation will help the system in that way.
I also think, you know, doing care differently. You know, on our campus at East 22nd and Community College, you know, we're looking to do healthcare differently, to create a health campus, to not only have acute care but complete care, to provide social determinants, all in one spot. And I think we are going to need to see more, you know, one-stop shops, especially for the population that we all talk about and we all treat. It is, I mean, for me, it's hard to make it to all my doctor's appointments. Imagine having all the things on board that the folks we work with have on board. It's just really difficult. But we ask them to go here for their addiction care and here for their mental health care and somewhere else for their primary care. Thankfully, we are seeing more and more integration of services, which is a step in the right direction. But I definitely think having a location where people can go and get what they need when they need it most is probably what we need to see. So kudos to UH, who is you know, reallocating resources and trying to make you know, lemonade out of lemons and really provide in those areas where they're vacating service additional wellness and support services for people on those campuses.
I think the other piece that I would add to this is consolidation may be down the path, maybe where we land, but at this stage in the game, I really think that there's a value in integrating the services that we have available and ensuring that community behavior, or it has the availability to support Metro Health, and that we can also pass people to them as we need to. That's the bridge that I think will help us at this stage in the game.
I couldn't agree more. It goes along a lot of what we've been saying about that collaboration, that communication. And when the question was brought up about the increase, in medical treatment, I immediately think of, the many children that I've worked with that are placed on medication and there's no communication to everybody else who's working with that child, and the barriers that sometimes can exist with where's the parent's education on the treatment, where is the follow-up with the therapy, the behavioral therapy, the behavioral interventions along with that, and so what are the dire outcomes of treating children and adolescents without all those safeguards in place in that communication?
Are the barriers there because there's, as the panel has said, they have to go here for this and here for that? Is that part of the breakdown in communication, that there's so many different places they have to go?
I would say that's a big part. I would say that in this field, I think a lot of us could say it can be overwhelming, the amount on your caseload, the amount of clients, and then what system is in place to support the communication that's needed, despite maybe how many clients or cases you're dealing with where you need to engage. So systems that could be put in place to better facilitate what that communication looks like, how somebody from a behavioral health agency can be collaborating with a doctor at Metro Health, at a UH. So a lot of times, like we're saying, the resources are there, and it's kind of like an increase in information, an increase in knowledge, an increase in communication, and getting on the same page.
Okay. Are you next?
Just to get in a Twitter question for those that are either watching or listening in, this person wants to know, there's a deeply held belief in our country that individuals recover from trauma or develop skills to manage mental health in predictable, linear manner. This is not reality and leads to systems regressing to a compliant and punitive approach. How do we respond?
I think my first response would be there's nothing linear in life, and certainly not in behavioral health. It is always going to be, paths are always going to be woven throughout your care.
That is true, but I guess it was around, are we treating people like that though? Even though life is not linear in the system, are we treating people like it is?
I think we do on the addiction side in particular. I think there's still a lot of moralistic kind of view of addiction, and our treatment system is still set up to be, you just go and you're done, right? Instead of treating it like it's a lifelong illness that you need ongoing care for with different levels throughout your life. We don't treat it that way currently. So I think in that way, I think there is still kind of a punitive approach of, discharging because you're non-compliant or that sort of thing.
So is it the stigma thing? Is that still real? Like, I know that people within the system try your best to help lessen the stigma, help people understand. But are there people within the system who still, carry some of these beliefs from the past and stigmas that they're passing on when they're caring for patients?
Yeah.
That was a quick answer.
Stigma is everywhere. It's prevalent. It's in people themselves, right? Depending on what source you look at, on average, it might take somebody 10 years to get treatment. Imagine if it took people that long to get treatment for some medical conditions. We would be in a lot of trouble, which is why we're in the trouble that we're in behavioral health. And yeah, I think it goes to, of course, stigma providers. It's those people. We don't treat that. It's in policy. And Eric mentioned it early on, right? How long ago was parity, and really where is it? And it's in payment models. Imagine if we, we took cancer and we made people go through levels of care. I mean, come on. So I think there are a lot of things that.
So just the way it's designed is in a way with stigmas in mind. The way the whole system is designed, right?
Yep. I think it infiltrates everything.
Yeah. Okay.
Good afternoon. Thank you for being here. The outrage over the Jane Edna Center and the lack of outrage over the treatment of the young people in the Cuyahoga County Juvenile Detention Center is glaring. All the young people in the detention center are not murderers. their kids, children, youth, and the detention officers are the ones who spend the whole day with them. And I'm concerned about who they're hiring. So my question to you is, if you were sitting on an interview team to hire detention officers for the Cairo County Juvenile Detention Center, what kind of questions would you ask to see if they're a good fit?
That's a tough question. It's very important, but a tough question. Any thoughts on that?
I would say an initial place to start when you're thinking about the population that they'd be working with is what is their background and training in terms of trauma-informed care. And so that once again speaks to what what our training programs are implementing, what additional training can be informed, because there's only so much we can take in our programs, but can that be provided to those who are at the front lines working with individuals who have experienced significant trauma?
Yeah, so if they don't come in the door with it, can they get that training immediately?
Yeah.
Any other thoughts on what would be a good question to ask, or how to assess?
Yeah, so one of the questions that we asked all the nurses that we've hired for the Cuyahoga County Jail is, why do you want to work at the jail? Where is your interest? Where does this come from you internally? Why do you want to work at the detention center? Tell us why.
Yeah, I mean, I was thinking along the same lines is, what are you most passionate about? Really finding out what somebody's passion is, where somebody's heart is. That they're not just there for, for for a paycheck, right? That they're there to really make a difference, and that there's passion. It's what everybody in here has. So.
Okay, thanks. I don't know if we're going to this mic next. I think we're at this mic next. You can go ahead, sir.
Hi, thank you for all your work and your comments today. My question is, with the knowledge that the majority of folks who cycle in and out of our carceral system have underlying mental health and behavioral health issues, what is the role of service providers, agencies, and institutions in advocating with policymakers and officials to move the conversation around public safety upstream and out into the community?
Upstream. I think you mentioned upstream, that we need to go upstream, right?
Yeah.
I think, there are.
He said, yeah. Would you like to elaborate?
we do need to go upstream, and there is, the 988 is just one part of the crisis continuum that Ohio is in the process of building out, and that's what really takes us upstream. Right? We've done things like train police officers so that when they intervene, they can recognize behavioral health symptoms, and we've opened the diversion center. By we, I mean Cuyahoga County. At the Adams Board has opened the diversion center, which is another place where you can take people. But then the point is that, like, way upstream, right? And that's what we're trying to get to with behavioral health urgent care centers, and making sure there's easy access to care so that you can prevent people from getting to the point where they have that emergency, right? We want to get it way upstream and really provide the treatment, which again just goes back to reimbursement and workforce and having the resources available to care for people.
And it's also about getting out there into the communities, walking alongside the community, leveraging those relationships, doing that engagement, working with the children, working on violence prevention strategies, right? Helping give people the resources that they need to succeed and be well as kids, before, a lot of that stuff happens. But really, I think working alongside the community, doing community engagement. We've been doing some great work. Rashawn has been doing some great work at our health system around this, and to really help us understand as a health system what that community really needs. So getting out there, boots on the ground, walking together hand in hand is a good start.
I think that's a great way to end this conversation. I would like to thank you, Michael, Julia, and Eric, and Jessica, for joining us here today on the City Club. Can we give them another hand? Today's forum is part of our behavioral health series in partnership with Metro Health, with additional support from Sisters of Charity Foundation of Cleveland and the Woodruff Foundation. We'd also like to welcome guests at the tables hosted by the centers, Metro Health, the Sisters of Charity Health System, and the Woodruff Foundation. Coming up next week, the City Club will host the final Public Square Forum of the summer on Tuesday, July 19th. Idea Stream's Rick Jackson will be here for that one. And he'll be joined by Lila Mills and Jim Crutchfield to talk about Cleveland's new nonprofit journalism initiatives. Then on Friday, July 22nd, we're back at the City Club to hear from Bashira Addison, Jill Rizika, and Renee Timberlake about what it will take for workers to thrive in the workforce. Talanje with Jumpstart Inc. will be moderating that conversation. And you can learn more about these and other forums at cityclub.org. And that brings us to the end of the forum today. Thank you again to our panelists, and thank you members and friends of the City Club. I'm Marlene Harris-Taylor from IdeaStream, and our forum is now adjourned.
For information on upcoming speakers or for podcasts of the City Club, go to cityclub.org.
Production and distribution of City Club forums on IdeaStream Public Media are made possible by PNC and the United Black Fund of Greater Cleveland, Incorporated.